Hi everyone, welcome to the first episode of the Anatomy Inquiry podcast. My name is Sorin.
My name's Philip.
And we are two students at McMaster University taking the third year / fourth year Anatomy Inquiry course. In this course, we engaged in learning anatomy through an inquiry-based approach. That means we were given the freedom and autonomy to explore whatever anatomical concepts most interested us. So my general focus over the semester, and the one that I will be discussing with Philip here, is pain and what is involved in the perception of pain.
Yeah, and I'll also be discussing the anatomy and a bit of the microanatomy of vasculature, specifically deep vein thrombosis and other kinds of thrombosis. And we'll try to really relate where we can the different points of connection between these topics.
So we thought we would do a podcast session together, as our two topics have somewhat overlap with one another. So getting us started, my initial process started off with identifying what pain is and what the perception of pain entails. So in this process, I actually came across a very formal definition of pain, Philip, and that is the International Association of the Study of Pain's formal definition of pain. So what that is pain is defined as being an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So here I want to just point out that the wording here allows for pain to be experienced by a person, even though there isn't any noxious or physical damage to the tissues. So in particular, the wording indicating the potential tissue damage. So that means that a person can evaluate their life, their environment, their scenario, and perceive pain based off of how they're observing and engaging with their environment. So I found that pretty interesting.
Yeah, that's pretty interesting. I do have a question about this definition. When it comes to things like, this may be a little off the mark for anatomy, but when it comes to things like nostalgia, where it's sort of the pain of the past, if we break that down, does that count? Like that sort of a mental phenomenon, does that also count under the umbrella of the definition of pain?
So that's actually a very good question. I know in part of my inquiry I also came across that pain is generally forgotten fairly rapidly. So in terms of painful memories, unless they are actively recalled constantly, which might occur in perhaps some psychological conditions where an individual might ruminate over their experiences. Generally, the most of the population actually tends to forget their painful experience, so much so that they might, once fully healed after an injury, they might not even be able to tell you if it was their left knee or their right knee that they had the surgery on. So for whatever reason, that's just a very normal human response, is the moving on from that painful event of the past.
Okay, so it seems like pain, when we're discussing this with respect to anatomy, it's more so in the present, the phenomenon that you're experiencing at the moment, and how that occurs on a, I guess, chemical level, as well as maybe due to the actual structures that are involved.
Yeah, so that's exactly it. That's a very good interpretation of it, and it can actually be broken down into, pain can actually be broken down into two major categories. And so the first being nociceptive pain, and the other being neuropathic pain. So nociceptive pain is pain that is brought up from the peripheral receptors that are responsible for the perception of pain, and these are called nociceptors. When these nociceptors undergo a depolarization, so essentially the nerve ending there activates, a signal is sent to the spinal cord, From there, at the dorsal column of the spinal cord, it sends off, that specific neuron sends off excitatory neurotransmitters to a second-order neuron. So this second-order neuron, once it reaches a certain threshold, again, it submits or sends that information up the spinal cord to the brain, reaches the thalamus, the relay center, reaches the somatosensory cortex, and pain is perceived by the individual from that specific site. And the particular types of stimuli that depolarize those nociceptors tends to be mechanical, chemical, or thermal. So that's one type of pain, Philip. The other major classification would be neuropathic. So anything where a nerve is compressed or damaged directly along its path will cause all sorts of unique symptoms.
I see. So when you mentioned the different types of pain, it actually kind of reminded me of what I went through a little bit in my research with thrombosis and vasculature. And one of the things about that, I guess a little bit of background, Sorin, is that I guess we'll go over some terminology to explain some of the concepts. So thrombosis itself is just when a clot forms within the blood vessels. And this is pretty general. So anything really, it could be a artery or a vein. And it's a topic that I actually stumbled upon because I thought it was one of those really important issues with 1 in 4 people dying from thrombotic conditions worldwide. So when we think of thrombotic conditions, we mean anything where there's a blockage, right? So that could be like a stroke, that could be something like a myocardial infarction, that could be something like the thrombosis, a deep vein thrombosis that we'll discuss in a bit. So essentially, because of the importance, I wanted to find out more about the actual makeup behind it, like how our body works, why these things happen, and where exactly it happens. And what I noticed is that there's a lot of classifications of thromboses, and kind of similar to how there's different types of pain.
Right.
There's you have venous thrombosis or arterial thrombosis, but venous thrombosis is more common than arterial thrombosis, and that's because of the makeup of the actual vessels. When blood clots form, they usually form in the deep veins, not the superficial veins, so near the musculature and not near the surface of the actual, I guess the veins found deeply embedded in the musculature. And the reason why is because there's more compression going on there and there's more blood flow going through there. And veins, unlike arteries, they're more collapsible.
Right.
So that sort of compounds with the fact that there's also a lot of pressure going down onto them from gravity. So when the arteries leave, there is pressure experienced by the arteries, the blood going through it, but the blood is traveling very fast and away. It's carrying it out, but all the blood starts pulling downwards. And you'll notice that when you are in a pool, for example, and you've sat down for a while in a hot tub and your vessels start dilating, that blood collects at the bottom near your feet, in your legs. So when you stand up too quickly, there's actually not enough pressure to go back up, but there's pressure going downwards. So it collects there. And that's why we see a lot of thromboses happen at the bottom. So whether that's still blood, whether that's due to a lot of other factors like chemical factors, those can all trigger thromboses.
That's very interesting. And remind me again, so arteries pushes blood to the periphery, so to your legs, and veins would bring them back?
Yeah.
Okay, gotcha. So these veins is where, specifically the deeper veins is where you would get these thrombotic events, so kind of the occlusion. And so the actual thrombus would form in the vein. Would it occlude at the site of the actual thrombus formation, or would it move often?
So yeah, that's a great question. It basically can move or it can stay where it is, and that's where we have the different types of thromboses. So if you have a thrombus that occurs in the deep vein and stays there, it's a deep vein thrombosis. If it gets dislodged by more blood flow, or if it just gets dislodged physically, then it can travel somewhere else. And when it travels to, for example, the lungs, that would and occludes a vessel there, that's primarily very dangerous because that's your site of gas exchange, but also it's called a pulmonary embolism. So embolisms are the term to refer to any kind of thrombus that moved from its original location to another location. And together, if you have DVT and PE or pulmonary embolism, that's known as a VTE or venous thromboembolism, and that's a pretty deadly combination. So that's pretty much the different kinds of terms we use to look at most of the major thrombotic conditions.
That's super cool. I've come across some interesting pain pathways from blood vessels. Before I kind of talk about that, you mentioned that VTEs or venous thromboembolisms are especially deadly. Why is that?
Yeah, so the risk of VTEs is twofold. One is the actual factors that play into the VTE of being dangerous, and then the VTE being dangerous itself. So long travel, for example, can cause blood to pool, can cause all these factors that make it more dangerous to experience a VTE. And then once you experience a VTE, it's very dangerous because it has a very high chance of recurring. So even if you get it treated fast enough, there's a very high chance of recurrence of a kind of thrombosis. And that's the problem because it needs to be treated really fast. If you think about it on a physiological level, you have your blood flow is mainly to transport oxygen and different gases to facilitate the gas exchange and nutrients. And if it's being blocked, then you can't get those things to parts of your body that need it. And especially when it comes to things like your lungs, which do most of the oxygen and carbon dioxide exchange, that's where you run into a big problem, because even a couple minutes without that kind of exchange, you're going to experience tissue death, and you're also going to lose consciousness in many states because you just don't have that oxygen going to your brain.
Okay. So from what I understand, one is it's particularly dangerous to have these thromboses forming because not only does it mean that you might have one thrombus which breaks off and becomes a little embolism flowing through your vessels, but you might have numerous of these. So very, very deadly. And then, and it's deadly because when it reaches these little thrombuses or embolisms, reach specific target tissues, be it your lungs, smaller diameter vessels, or the peripheral tissues, it can cause just a lack of nutrient flow and gas exchange and whatnot to the tissues.
Yeah, exactly. So that's a danger of it, and it compounds with a lot of other things. So just the fact that having a thrombosis, having those things can also increase your blood pressure, can cause a lot of other risk factors for other diseases.
Right.
It's just something that snowballs. And so I was wondering, when it comes to pain, are there things that make it worse? Are there things that can make it chronic, for example?
Yeah. So a few things before I kind of talk even about chronic pain. I see a bit of overlap in our topics in that I actually came across some structures called Nervi Vasorum. And so these are nerves that actually reach out their nerve endings and integrate with the blood vessel wall. So something like a vein or an artery would have actual mini nerves which innervate them. And so if there's something which occurs to that blood vessel that this nerve picks up on and it doesn't like, what it actually does is it secretes various neurochemicals or neuropeptides in and around the region of the irritation. So if there's a DVT, I would imagine, or if there's a cramping of a muscle, essentially the Nervi Vasorum would send out these chemicals, and surrounding nociceptors in and around the vessel would activate.
Okay.
Have you come across like pain-related perception in and around blood vessels at all?
Yeah, so one thing that clinicians use to diagnose DVT very quickly without the use of any machines or any equipment is the Holman sign test, where it's a physical examination and they extend the knee and raise the patient's legs straight to around 10 degrees. and then passively and abruptly dorsiflex. So bring it towards the center of the body.
Okay, so bring the ankle
upwards.
Yeah, upwards. Okay, got it.
Upwards. And then they squeeze the calf with the other hand. And so if there is a thrombosis, there may be an excruciatingly sharp pain. And I guess the reason behind that, after hearing your explanation behind these nerve connections between the vasculature and the nociceptors, is exactly that, is that you're triggering that response from the surrounding nociceptors, because there's literally a thrombus, a little ball of a clot, actually pushing against the walls, which can definitely be painful, because although vasculature is stretchy to some extent, it's not that stretchy, and if you really stretch it and strain it, there will be some sort of pain associated with it, as with any.
Gotcha. So what you're saying is, the clinician would do this test, place stretch on the calf muscle, and that would then also compress the vessel a little bit, and the patient would feel pain along that blood vessel, specifically where the thrombus formation has occurred.
Yeah, I would assume so, because the deep vein is in that area, and you're also performing the test on the lower extremity.
Yeah, okay, very, very cool. The other thing that I did come across in terms of blood vessel related symptoms was actually into my inquiry of what different pain is experienced like. So what clinicians would term symptomatology of pain. And what I did come across is that pain can be perceived via different specific terminologies. So, for example, a patient might describe their pain as being sharp, whereas someone else might say, "Oh, I feel some dull, achy pain," or else someone else might say tingling, numbness, or shooting. So my question was, why the difference? So what's involved and what's the distinction here? So just to give some additional information on that line of inquiry for me, generally when people express pain as being felt as being sharp, this is in reference to superficial tissues where some form of noxious stimuli is being applied to. So be that too much mechanical pressure, too much thermal pressure, or too much chemical imbalance to that tissue. And so, and that would occur in the superficial tissues. That would be the skin or the mucous membranes. Then I came across the dull and achy pain. So people that experience dull pain, achy pain, those are in the deeper tissues. Same thing, nociceptors are activated just from muscles or bone or organs. And then when I came across burning, numbness, shooting, lancinating, or tingling pain, usually that's when a nerve is actually damaged. So that's the neuropathic pain I was telling you about earlier. But then I came across a very unique and distinct type of symptom, which is cramping. So this is when a structure within a muscle is being compressed, and that would activate the nociceptive nerve endings. Now, cramping and the test you actually just mentioned there, the Hohmann sign, seem to overlap very much, because it seems that when you apply stretch to the calf muscles there, the gastrocnemius or the soleus, that in and of itself compresses on the blood vessel and causes torque and causes activation of nociceptors where there is too much mechanical irritation. I found that very interesting, that what you mentioned there. So I could also see someone experiencing the calf spasm as well, and also experiencing pain related to their blood vessels. And lastly, the last pain symptom that I came across is throbbing. So a patient might experience, I'm experiencing some throbbing pains through my calf, for example, and that is very much isolated to blood vessels in the pain perception. And that is also nociceptive activation. So that was actually very interesting to see the overlap there. So again, just to reiterate, sharp is superficial tissues, dull and achy is deeper tissues. If someone says, I'm feeling burning, numbness, shooting, lancinating, extremely sharp sensations, or tingling, that is usually indicative of neuropathic pain. Cramping is the compression of a structure within a muscle, and then throbbing is when the blood vessel itself is being irritated, and usually the throbbing is almost like a pulsating sensation, and that's just because of the heart pumping and sending blood flow through that irritated vessel.
Yeah, that's really interesting. And it really, the different types of pain reminds me a lot of the different types of, I guess, vasculature and conditions that we talked about. But on top of that, I was thinking maybe of zooming in on the microanatomy, and because we've been going over the large outcomes, the different sorts of structures involved with this. But if we zoom in a little bit, I do want to touch on something I found really interesting when it came to the actual receptors and the different mini structures that we find inside different parts of the vein. So the vein has valves, and that's an interesting part of it, because the arteries don't really have that need for the valves, aside from near the heart, because they're exiting and you're preventing black flow right there. But aside from that region very close to the heart, where it's exiting the heart, you don't really see valves around the arteries, but you do see a lot of them in the veins. And that's because artery walls have a lot of musculature within them, versus veins, they have very minimal, if any. And this outlines a big difference, because they are experiencing different levels of pressure from the blood flow itself, but the pressure is from the flow. It's not from the actual movement of it due to gravity, for example. So vessels like veins experience a lot of pressure from gravity, but they don't experience a lot of pressure from the speed at which the blood is flowing through them. So at the arteries, it's right where the heart contracts and you get all the blood flowing through it. So it's going away from the heart and you're getting a lot of pressure on the walls that way. But you're getting pressure, on the other hand, it is a lower pressure system, but you're still getting some kind of pressure from in the veins. So it does require less musculature. But because it has less musculature to resist it, it also can't really have that constriction as much. So how does it really flow back? That's why we have valves, to prevent the blood from flowing backwards and messing up your whole rhythm and cadence of that blood flow. And you'll see that there's more and more valves the deeper you go, because again, there's more pressure, there's more musculature, you're going further downwards, there's more gravity and just pressure from all the blood on top of the blood that is near the bottom to prevent that black flow. But on top of that physical reason for having these valves, the endothelium, so it's just a lining that lines all the insides. That's what an endothelium is. It's just a thin layer of cells that lines the insides of both the arteries and the veins. But the endothelium specifically in these valves, so between where the valves are and the walls, that's what we call the valve sinus, that space right there. And then in that valve sinus, the epithelium is actually special because it has these receptors called EPCR, or endothelium protein C receptors. And two things to note about this receptor is that it needs to be bound to the membrane to have the proper structure to do its function. And the second thing is that its function is to prevent coagulation. So your body actually has this natural defense mechanism against thromboses, and that's part of that system. So what it does is it takes this inert protein called protein C, and it will convert it alongside with the help of another protein called thrombomodulin. And together, they'll convert it to activated protein C, which really is a signal alongside some other proteins to tell your body to, hey, break up these clots to prevent that clotting from happening. So it's a pretty necessary part of the chain of signaling when it comes to that. Now, EPCR is also kind of the reason why we actually experience thromboses, and not because it's there, it's actually because of the lack of EPCR. And that's what contributes to differences in populations being more at risk or less at risk of developing thromboses or thrombotic conditions. So EPCR, I noted that it's connected to the tissue, but if it gets separated from the endothelium and gets cleaved off, for example, or just gets knocked off, then, or even gets created outside of the endothelium, then it becomes soluble, or it is soluble. And that's called soluble EPCR, SEPCR.
And that's soluble in the blood?
Yes, it's soluble in the blood. So you do have soluble EPCR. Everyone does. There's a balance of it, but you don't have a lot of SEPCR compared to EPCR. And that's because SEPCR actually is a competitive inhibitor of protein C. So it will latch on to protein C because it is an EPCR, but it won't have the same effect. So it'll not activate it. And that'll prevent the actual non-soluble EPCR from converting it to activate it. And that's a problem when you have it in high amounts. So in low amounts, it's good for homeostasis. You can balance things around. But if you have it in very high amounts, like some of the population does, that can actually cause problems. And it's interesting, they did studies with healthy individuals, and they found that around 20 to 30% of them actually have a inheritable genotype for EPCRs that encodes for more soluble than non-soluble. So those people are more at risk, which you'll see is why you have healthy people who are just at higher risk of developing thromboses.
Right. So just to summarize here, make sure that I understood it. So essentially, if there's too much soluble EPCR or too much soluble PCR or SPCR, so if this receptor just isn't bound to the membrane, it's not able to induce anticoagulation activity. So anticoagulation activity is important because this prevents the platelets and various other structures from creating a blood clot. Is that correct?
Yeah, exactly. And I was also thinking that this receptor system, although it's slightly different, there are receptors involved in pain as well.
Yeah.
Right? So would you be able to explain that a little?
Yeah. So this is delving a little bit more deeper into the actual kind of microbiology involved. And I think this is interesting because here is where we can start to explain some of the genetic differences within the population. So similar to what you said there about these protein C receptors and how they have different variances from individual to individual on how well they attach and align to the membrane, we also have variances in the types of channels that are located on pain receptors. So we said pain receptors are nociceptors, and so there's variances in the subtypes of channels which allow for the activation of these nociceptors. So one specific type of channel is the TRP channel. And so these are what we term as being transient receptor potential channels, or TRP channels. And we have different subtypes of what I'm going to term as TRP channels. And so these could be, TRP V channel, channels, TRP M channels, TRP A channels. And each of these channels, essentially, when a certain threshold of temperature is reached, or a certain a substrate interacts with the channel, it actually causes that nociceptor to depolarize. So I found that interesting. So essentially, if your tissues get to be too cold, different channels would activate these pain receptors in the skin, and then you would feel, a painful cold stimulus, as opposed to when your skin reaches too high of a temperature, different channels would then activate. So, for example, the cold-related stimulus channels are usually the TRPA receptors or TRPA channels, whereas the high temperatures receptors or channels are the TRPV channels.
Yeah, so speaking of the high temperatures, we've definitely heard of people eating hot peppers.
Right.
And so those are not really hot in temperature, but they do feel spicy or painful sometimes. Is that activating that same receptor, but as a different substrate that you mentioned?
Yeah, so you got it. So it's either temperature that could activate these, or it could also be substrate interactions. So for those hotter temperature channels or higher temperature channels, the TRPV channels, they can also be depolarized by something we call capsaicin, and that is found in hot foods of sorts, or in naturally occurring in hot peppers. So essentially that experience of hot stimulus when you eat food, that is your TRPV receptors being activated. And on the other end of things, when you, let's say, apply some cold rub to help relieve your pain, that usually contains menthol. And menthol would activate the other end of the channel receptors, and that would be your TRPM channels in particular. So that was very interesting. So this actually would explain some of the variation within the population in terms of the experience of cold or hot temperature. If, let's say, there's less TRPM channels on nociceptors, someone would be able to withstand cold temperatures for longer. So have you seen those polar dunks or those ice baths? Yep. So those can be quite intense for some people, but a lot more reasonable for others. So I found that interesting. Also, just from a little biochemical standpoint, is how this explains the genetic variation behind people's different perceptions of pain.
Okay, that's really interesting. So really, when it comes to pain or even the vasculature, there's a lot of differences in the population on a genetic level, which would explain the variances. And but I guess zooming back out to a macro level, when it comes to treatment of pain, or even going back to vasculature, for vasculature, we have medications,
Right,
that we use to treat pain, or in this case, not really the pain itself, but the causes of the pain, which is the thrombosis. And the therapeutics are centered around anticoagulation. So it's different between patients because we need to be considerate of other underlying factors. So if somebody is at more risk of bleeding, putting a anticoagulant is kind of dangerous in some cases, because if you're already at high risk of bleeding and you bleed more, you could lose a fatal amount of blood, and that is not something that we'd want as well. So we'd have to consider different types of anticoagulants because they do work on different pathways. So you might have heard of warfarin.
Yes.
And warfarin is a vitamin K antagonist. So vitamin K has this complex in your body, in the liver specifically, that kind of reacts with other factors in order to coagulate. And so we're actually stopping part of the coagulation cascade by inhibiting the action of vitamin K, which is another thing that isn't part of this EPCR anticoagulation that we talked about, but it's addressing the factors that are causing coagulation, which is kind of different in a sense, because stopping coagulation from occurring versus breaking up coagulation that has already occurred are two different things, but they do accomplish the same end goal. But the difference is there, and it can also mean the difference between treating different types of populations. Other steps in the coagulation cascade such as inhibiting factor XA, for example, can also be good for treatment. You might have heard of rivaroxaban or apixaban, and those are commonly prescribed as well. But those just block a different step of the cascade.
Gotcha.
And you also have heparin, which is the last example I'll just cite, and that is also an anticoagulant. So really, you have a lot of different drugs that aren't exactly one size fits all. You'll consider the different aspects of it. And I'm sure it's the same with pain, where you have different types of treatments for it.
Right. Yeah. No, that's a very good point. And I wonder, have you come across any discussion on the holistic treatment of thrombus formation? So I know here you mentioned medication, but how about like lifestyle changes or factors, anything there as well, or?
Yeah, so definitely lifestyle plays a big role in a lot of this. Even the risk of thrombosis is due to things like over 4 hours of long distance travel.
Gotcha.
So really just sitting in a sedentary position for a long time.
A lack
of movement. So increasing your exercise can prevent that. And just moving around every couple of hours or so before you get to that point where your risk is increased. But on top of that, exercise also helps against creating free radicals in your body, or prevents that really in some sense, because at a certain point when you age, really when your body goes through different processes, you also have free radical formation, and exercise can trigger a lot of a production of different compounds, and those compounds can help with mitigating those risks.
Oh, okay.
I think when it comes to exercise as well, you're not just increasing the amount of different substances or whatever your body is producing. You're also strengthening your cardiovascular health in general. So having your heart really beat at a faster rate for periods of time can make your heart beat slower throughout the rest of your, I guess, lifespan in general when you're not moving.
Right.
And that's one of those things where it's a whole different discussion at this point. But one thing to note is that it is important, like having a lower resting heart rate is something that can be achieved by exercise.
Right.
And then that can lead to lower levels of risk for other things. And it's been shown to be correlated with a longer lifespan.
Okay.
So in general, it's a very wide topic. So I don't think we'll have enough time to go into it. But lifestyle choices like nutrition, eating things that are high in antioxidants like vitamin C, those can all help with preventing damage in the first place that can lead to the formation of thrombus. And I guess for some listeners out there who might be wondering why exactly free radicals, those things could cause damage in the first place, or even thrombosis, it's because free radicals are basically electron stealing agents, and these molecules will rip apart your cells, and that will cause inflammation. That will cause damage in your body, and you're going to try to repair it, and that's where the clotting comes in from. And if we take something like vitamin C, which has an excess amount of electrons, that'll donate it to those electron stealing molecules, and that will prevent that cascade from happening. So it's a preventative measure in that sense.
Yeah, that's very interesting. Another thing that also came to mind as you were talking about lifestyle factors there, and you mentioned nutrition, I've also come across or heard of plaques or plaque formation in blood vessels. So is there some kind of correlation between, like a high-fat diet and perhaps, these atherosclerotic plaques forming, and let's say like one of these plaques breaks off? Does that cause coagulation to occur, or how does that work?
Yeah, so those things are definitely linked. You don't have thrombosis, you don't have atherosclerotic plaques in isolation from each other a lot of the times. Many times
They come hand in
they come hand in hand,
Okay.
because you're narrowing the vessels
Right.
with the plaques, and those plaques can cause that trouble with blood flow, and then that can cause turbulence, and you'll end up generating thrombosis. So really, it's a positive feedback loop where one condition can lead to another and can lead to pain as a result. Almost all of these different conditions can lead to pain of some kind.
Right.
And that's kind of why you can't really separate, for example, one condition from the other completely.
Right. And by positive feedback loop, you mean it becomes this prolonged process where, the plaque forms and then it grows larger. And when it grows larger, it can then break off. Perhaps a thrombus can form, or partial occlusion of a blood vessel can form. And all of a sudden, as you were saying, you might get some pain or nociceptor activation via perhaps those Nervi Vasorum and the surrounding nociceptors. And all of a sudden, this person starts to experience that, throbbing sensation in their lower extremity, specifically a deeper vessel or a deeper vein, you were saying. So that's very interesting how it kind of can progress almost untreated or uninhibited naturally by the body. That's very cool.
Yeah, so I guess really to end things off, when it comes to, we talked about the vasculature and pain,
Right.
and the different parts that contribute to both of these things, and on an anatomical level and on a micro level as well. I guess to the listeners, what sorts of things do you want to really say are your main takeaways from this whole experience?
Yeah. So this whole process of learning and exploring our anatomical topics has been absolutely amazing, I think, just from an inquiry standpoint. So I found a lot of my understanding on pain could really use expanding on. So in particular, things that I took away is that pain can be perceived peripherally due to actual irritation or noxious stimuli to the tissues, or it could also be perceived in the brain if someone is expecting to feel pain. So that perception can occur in the brain, even though there is no physical damage to any tissues. I thought that was very interesting, especially learning and hearing about specific case studies of this occurring. And then I also found it pretty neat that there's classifications of pain. So broken down into nociception and neuropathic pain, and sometimes people can have both presenting, kind of as a mix. And then when people do have these painful experiences presenting, they can express them in different terminologies. And usually each of these terminologies, be it sharp, dullness, burning, aching, shooting, perhaps throbbing or cramping, these actual symptoms that they experience are actually associated with either one of the two subtypes of pain or the location of the tissues that are being affected. So I thought that was very neat. And it was actually really cool to see the overlap between blood vessels and vasculature, mechanical stressors, be it through kind of thrombus formation, and how the Nervi Vasorum interact and inform the brain of these painful stimuli.
Yeah. And for me, I think my main takeaways, there are a lot of them that we went over in this podcast, but I also want to touch on the things that I realized after the fact was that really thinking about vasculature as its own separate topic is something that I never thought about before, because I always thought of it as a connecting point between different organs that we tend to really give emphasis to. Like the heart is very important, and there's other organs as well that it connects to, supplies blood to. But looking at the different parts of the actual vessels, like the actual highway transport for the blood, is something that I didn't think would be so in-depth and would have a lot of nuance to it, and would have so much interplay with other things like pain or different phenomena that really makes it an important topic.
Right. What I thought was particularly cool is to see the amount of variance in vasculature. For example, superficial veins versus deep veins, and how there's different occurrences of thrombus formation there, and how the valve rate would vary from a vein higher up in the body versus down in the leg. That was also very cool to see. It makes sense from a pressure difference standpoint. So yeah, that was really neat to see, as you say, that nuance and value that vessels hold.
Yeah. Honestly, I think we could go on for a very long time on both of these topics and find connections between other anatomical topics. But I think we will save that for another discussion and end it off here.